Yes, sir. We can start. Three, two, one.
Good evening, everyone, and welcome to yet another masterclass by none other than Dr. Abha Majumdar. Good evening to everyone. And today we have a very hot topic for discussion, which is social oocyte freezing. Nowadays, because of the education around it and the celebrities undergoing this procedure, there has been a lot of awareness in young women. And seeing that MNCs are even sponsoring this treatment of theirs to give them a reproductive freedom. Let us hear the perspective of an infertility specialist, none other than our own Dr. Abha Majumdar, from a center where we have highest number of oocyte freezing cases. Let's hear it from ma'am about whether it's hope or a hype. Over to you, ma'am.
Hi, good evening, everyone. Good evening, Tejashri and Mr. Vishal, for always supporting us in this endeavor of dispersing sort of good ethical medicine. And thank you so much. So today our topic is very interesting. I thought, this would interest all gynecologists across board, all obstetricians, because social oocyte freezing is becoming very popular even in young doctors. So how much of hope it is and how much of hype it is, we'll discuss today. Um, why the need for social egg freezing has come up? Because now we have generation changing from the baby boomers where we were born into X, Y, and Z, and maybe the alphas also. And with this change in generation, the age at first delivery is continuously rising. And we all know that age is the most important indicator of fecundity and fecundability. There is no known treatment to avoid or reverse age-related natural decline in fecundity. And social changes are happening, societal changes, women empowerment. They have led to narrower gender gaps in career opportunities. Girls are going in for every type of job, may it be a professional job or entrepreneurs, or even for jobs like driving and driving trucks, driving trains, driving planes, being pilots. So everywhere girls have stepped in. And probably that is where we have had we had the need of reproductive choices, because a lot of these jobs don't allow you enough time to look after a child, and therefore a tendency towards delayed childbirth. So social egg freezing is planned oocyte cryopreservation. We know that our numbers are declining, the quality is declining with age. So at a age where the numbers are good and the quality is good, if we can preserve eggs, does it give us reproductive autonomy at a later age? Yes, well, it can give women an opportunity to extend their reproductive lifespan and time to fulfill educational and career aspirations as well. So what is social egg freezing? In very simple words, it is for non-medical reasons. There is no emergency to do it, but this refers to the process of freezing a woman's egg to preserve her fertility for future use whenever she desires fertility. So I just want to show you what happens with age and oocyte quality. The first thing is that as we age, when we are less than 35 years, we have a very good mitochondrial viability in our oocytes. And as we age, just cross 35 years and above, we find that the mitochondrial function is being impaired. The granulosa cell apoptosis increases and oxidative stress increases in these oocytes. So all this leads to reduction in egg quality. What else happens? The euploidy rate of embryo reduces. What is the connection between age and mean number of eggs needed for one euploid blastocyst? Euploid means chromosomally normal. We all know that chromosomal abnormalities increase as age advances, and it has become a rule to test all pregnant women for Downs or all type of triploidies after 35 years also. So the ART calculator developed by the Poseidon group shows that if age is less than 35, you just need 6 oocyte cumulus complexes to have one euploid blastocyst, because the euploidy rate in the oocyte is about 60%. Euploidy rate in a blastocyst. in the embryos which form out of 6 COCs. So if the age goes up to 40, then we need at least 10 good eggs to make one euploid blastocyst. And as age goes beyond 40, we need almost 16 or maybe more oocyte cumulus complexes to make one euploid blastocyst. Now, this is making of one euploid blastocyst. It doesn't give you a chance of pregnancy 100%. It will give you a chance of pregnancy as it is in that ART center. If the ART center has an implantation rate of 50-60%, one euploid blastocyst will implant 50-60% and give you a chance of pregnancy 50-60. So, at every age, you want at least 2-3 euploid blastocysts to give you enough chance of pregnancy within 2 or 3 transfers. So, then comes age and ovarian reserve. Now you see this graph, how AMH, which indicates ovarian reserve, is high at 25, starts declining with age, and at 40, it comes to a minimal level of around 1 nanogram per ml. And after that, it declines further. And after 43, 44, it may even reach near zero and levels. So, it's important to remember that these are just general guidelines and individual results can vary. Very young girls can have a much lower AMH and much older women can have a better AMH, but the oocyte quality will definitely decline. The aneuploidy rate will definitely change. Euploidy rate will decline and aneuploidy rate will go up. Factors like genetics, medical history, and lifestyle can also influence ovarian reserve. For instance, extreme obesity reduces ovarian reserve faster. Genetics, the mother had early menopause, the daughter might end up in early menopause. Medical history, history of chronic infections like tuberculosis, HIV, hepatitis, all can lead to rapid depletion of ovarian reserve. Surgical history of having endometriotic cyst removed or any other ovarian surgery might also reduce the ovarian reserve dramatically. Having known that, why do we need to know the ovarian reserve before we are going in for a woman to preserve her oocytes? Now, these are 4 situations where the ovarian reserve is declining from just maybe 1 or 2 antral follicles to 4 or 5 antral follicles to about 10 antral follicles to a lot of antral follicles. If the ovarian reserve is so low as in the first case where I've made a picture presentation of an ovary, these patients are not fit for oocyte cryopreservation even if they are young. Why is it so? Because they will need multiple cycles of egg collection to collect, even if they are young. 5 to 6 oocyte cumulus complexes are needed for one euploid blastocyst. So we will need at least 15 oocytes. And to get 15 oocytes, we may need 10 to 15 cycles for such women. It is not really reassuring at all. Then comes the second group, women with low ovarian reserve, but not so low. And especially the older women, they will have smaller number of oocytes retrieved with every stimulated cycle. And therefore, they will also need multiple stimulated cycles to optimize the oocyte number. Suppose we freeze 4 or 6 or 8 oocytes, mature oocytes, they may not be enough as an optimum number, and she may have a false hope on this that, oh, I have my oocytes frozen, but they may not even produce one euploid blastocyst, or if that one euploid blastocyst fails to implant when it is converted into an embryo, then they have no other oocytes left. So multiple stimulated cycles are required for women who come of older age or who have a lower reserve. Then comes the normal reserve women. Generally, they on gonadotropin stimulation will make 10 to 15 or 20 oocytes complexes also. And hence, if they have 15 mature oocytes preserved, then we can expect them to have young women, less than 35, 3 or 4 euploid blastocysts, which should be enough assurance that they may end up with a live birth. However, everything depends on not just the number of oocytes, the sperm and oocyte interaction also. So the fertilization rate is also important in these later on in life when they pick up their partners and they want to have a baby. And the last is uh, ovaries, which are very sort of heavily loaded with oocytes, the PCOS women, or women who are called as high reserve women, high responder young women. Here we have to be very careful to calculate the gonadotropin dose carefully, so that along with receiving an adequate number of oocytes as per the woman's age, we can prevent hyperresponse and ovarian hyperstimulation syndrome also. So all four categories can have different responses to ovarian stimulation. And the first category I would refuse, and I have refused girls who had come to me with a very, very low ovarian reserve. And when I told them that you will have 1 or 2 oocytes, they said they've already gone through a oocyte cryopreservation cycle somewhere where one oocyte was cryopreserved. So I told them, see, now what I'm telling you is the same, and you will need at least 10 oocyte cryopreservation cycles, whether we stimulate you or we stimulate you less. I don't think we would be able to get more than 1 or 2 oocytes in every cycle, and they are not fit for cryopreservation. Now, why social egg freezing is on the rise? After 35 years, fertility decreases. And as a result, fecundability decreases and fecundity also decreases. The oocyte quality decreases by, number one, I told you, mitochondrial aging. Number two, chromosomal breaks increase in oocytes lead to aneuploidy in embryos. So we have lesser and lesser euploid embryos with more and more oocytes aspirated. And the ovarian reserve also starts decreasing rapidly, as you saw that AMH levels go down. So what happens with maternal age? You see at 37, everything is crossing each other, but the live birth rate goes down with age, and the aneuploidy rate goes up, miscarriage rate goes up after 37 years of age. So women opting to freeze their eggs earlier can choose to delay childbearing. It is very important that women come at the right age, at least, if not before 35, before 37 for sure. Now, what are the indications of oocyte cryopreservation? We've spoken about social egg freezing right away, that we want to preserve future fertility to delay childbearing. There is no other reason for a woman to go for social egg freezing. But then there are medical reasons also for oocyte freezing. And one is we get a lot of young girls who are to undergo cancer chemotherapy or radiotherapy. They come to us just before chemo or radio, sent by their oncologist, because they are all becoming sensitive to fertility preservation and autonomy of reproduction for women also. So there we may have to do it on an emergency basis if the girl is still not married. And we just stimulate her ovaries, we collect all the oocytes, and we preserve them. If she has a partner, then we can make embryos and preserve them and let the woman go through the whole chemo, radio treatment, and then come back when she's cured, or however, whatever the course of her onco treatment goes. And then others are known cases of low ovarian reserve, like women or girls who have been suffering from endometriosis as young girls, or who've had to undergo surgery for endometriosis. And the ovarian reserve has dropped because of the disease or because of surgery, or those who are suffering from autoimmune diseases, and that is known to them from early ages, or genetic causes, if known causes are there, and we know that her ovarian reserve will deplete faster. Then these are medical reasons where even in 20s, girls come forward for oocyte freezing. And then there are emergency reasons. A lot of time when we are doing IVF and we've taken all the oocytes and we've not kept a semen sample as standby, the male partner is very anxious and may not be able to give semen on the day of oocyte pickup during the process of IVF. Then we have this problem that, we have to freeze her oocytes and then let the husband come back in another day when he's less tense mentally, give a sample, and then we can thaw and fertilize all these oocytes. Now, what are the ethical arguments in favor of social egg freezing to preserve future fertility? Very well, we all know it enhances reproductive autonomy in women who aspire for their career, profession, whatever, or even education. And the pressure to find a partner also goes down. Parents start worrying that, oh, my girl is 32, 33, 34. We've not found a partner. How will she conceive later on? So if she's frozen her oocytes, then she can ask them to relax. Maybe she can relax also. And it is a lot of cost saving compared to future IVF cycles, because at an older age, when you go through IVF cycles, you may have to go multiple IVF cycles, and two, it becomes more expensive. It also precludes the need for donor eggs if spontaneous pregnancy does not occur. I mean, girls do agree for taking donor eggs when the demand pressure of the society, of the in-laws, of their own family is so much that you must produce a child and they're not being able to, then they just quietly opt for donor oocytes to stop the society from, sort of pressurizing them that why don't you have a child yet? And it may also improve a woman's ability to organize their education, work, and family with less pressure from their biological clock. What are the ethical arguments against social egg freezing to preserve future fertility? The intervention may be too physically invasive and risky to perform when there's no immediate threat of infertility. I mean, maybe so many women are fertile even at the age of 40, though the percentage is small. So it is a physically invasive procedure. Limited success rate as age and quality impacts outcomes. So the success rate is low. Suppose a woman comes at 38. A lot of women used to come at 40, 41, 42 to preserve their eggs. Now there is so much awareness that girls do come at 37, 38, 39. And there are girls who come in their early 30s also. Then we don't know the shelf life for cryopreserved oocytes and the long-term safety of the offspring. It is yet not established, though it has been seen that once cryopreservation of embryos or oocytes is done, 10 years they can be kept safely. The studies on offspring by cryopreserved oocytes and embryos still continues, though there are small epigenetic changes seen in children. I mean, it is practically safe, except for small anecdotal cases where they have probably thought of a oncological risk or of a epigenetic risk. The last is it may provide a false sense of security, like an insurance policy. Women just feel that whatever eggs are frozen, oh, I am absolutely okay now. I don't need to, think about marrying or thinking about getting pregnant till I'm 42, 43, because 40 is a very young age now with the longevity going up. All women who used to have menopause in their 40s have menopause in their 50s, and we all live for across 70, 75. So longevity is increased, and women feel that, I can reproduce much later when I'm totally settled. So that is what happens. Now, what are the events in a natural cycle? In a woman, in humans, there is selection of one dominant follicle at ovulation, and the rest, which are the cohort which grows according to what ovarian reserve a woman has, it all undergoes atresia, and one dominant follicle is selected. What happens in a stimulated cycle? Well, when we go on giving gonadotropin and there's no decline in the FSH levels, like you see here, the FSH is the black level. As soon as one dominant follicle is selected, there is a decline in the FSH levels here, so that only that one grows which has got enough FSH receptors. Whereas here, where we are going on giving gonadotropin injections, the FSH level does not decline. It continues to rise so that more follicles are selected for ovulation. And hence we can pick up as many follicles as we want according to the patient's cohort of follicles, which again depends on their ovarian reserve. What is the egg freezing process? Well, day 1 and 2 may we just do an initial consultation and fertility assessment. Ideally, fertility assessment can be done even before taking the girl for oocyte cryopreservation. So we do a hormonal assessment, her ultrasound assessment, and tell her what are the chances of as many eggs as we need for her being made in one treatment cycle. From day 2 or 3, we start ovarian stimulation and monitoring. So 3 to 10, she takes subcutaneous injections herself through a pen, like an insulin pen, which is very easy to institute people who are on insulin, before their meals, they just sit and inject insulin through a pen and keep it back in the door of the refrigerator. Well, these injections are given for 4-5 days, and then she's called for monitoring through ultrasound and blood tests. And then we know that which is the time when adequate number of her follicles have reached dominance. And that is the time when we give a trigger shot and we prepare her for egg retrieval. It is generally around day 11 to 13. So a trigger shot is given in the night, and 36 hours later, the egg retrieval day is done, which is generally around day 14, but this day can be a little earlier or a little later according to the girl's response to ovarian stimulation and her reserve also. And then the most important thing, which I've highlighted here on day 15, 16, once all the oocytes are retrieved, they are handed over to the laboratory, to the embryologist for evaluation. Mature oocytes are identified from all the retrieved oocytes by the embryologist. These oocytes are frozen by the procedure of vitrification, which is rapid freezing to the temperature of minus 197 degrees centigrade. And oocytes are frozen in cryopreservation straws in groups of not more than 2, 3, or 4 oocytes per straw. And then the post-procedure storage and ongoing monitoring of frozen eggs is done. They are in specialized tanks. They are frozen at low temperatures regularly. We monitor the storage conditions. We replenish the liquid nitrogen and ensure that the viability of these frozen eggs continues till as long they are frozen. So what is oocyte freezing timeline and cost? One cycle stimulation and freezing requires 12 to 14 days, starting from day 2 of a woman's cycle. So we need approximately 2 weeks of the woman's time, starting from day 2 to day 13 or 14. Women who have a low reserve or advanced stage, more than one cycle of stimulation may be required, which can be undertaken as following. Either we do 2 stimulations in the same cycle for women who have a sort of possibility of only having oocytes collected in 1 month. So we do 1 stimulation in the follicular phase, collect oocytes, and after 3 or 4 days, we can again do a second stimulation in the luteal phase and collect oocytes again. These oocytes are equally competent, whether they are collected in the follicular phase or luteal phase. And we call this type of stimulation as duo-stim. There is also another stimulation, which is bi-stim, where we can do 2 subsequent follicular phase stimulations. Cost of 1 cycle at a center is about 95,000, which includes all hormone testing, all ultrasound monitoring, oocyte retrieval under general anesthesia, and oocyte freezing for 1 year. Yes, when you have to freeze it for more years, then every year it is approximately 10,000. Drugs for ovarian stimulation vary. If the girl is young with good ovarian reserve, the drugs could be just for 30,000 odd Indian rupees. And if we need more, then it could go up to 70,000. I've given an average of 50,000 depending on the ovarian reserve. Now, ASRM 2023, they said we can use, instead of just social oocyte freezing, we can also call it planned oocyte cryopreservation. Apart from social egg freezing, we can also call it freezing for non-medical reason, or oocyte cryopreservation for anticipated gamete exhaustion, or we call it age also. So rationale is the age at first births have been rising since 1970s. Many factors contribute to this trend, but it is well recognized that increased access to education and participation in the workplace is the central reason for girls delaying childbirth. One study cited the lack of partner as the most common reason individuals elect to undergo planned oocyte cryopreservation. And when individuals seek children at the time when their own oocyte quality is compromised, planned ovarian oocyte cryopreservation provides an additional option in this circumstance. These women can sometimes get pregnant absolutely normally, but if they don't, these cryopreserved oocyte can be an option for them. And it will allow some couples a chance to have genetically related children at an age where we know that their chances of reproduction are very low and they have tried enough and they are not being able to conceive. So one of my postgraduates fellow did follow-up survey on the reproductive attitudes and experiences of women who underwent social egg freezing at our center in Gangaram Hospital. And what she did was that we do egg freezing since 2008, but it has been on a low egg. We started social egg freezing from 2016 only. And if you see the trend, it is going up, and it has gone up so high now in 24. However, the social egg freezing numbers are 86 only. But then what we did was we only chose women up to 2022 who had frozen their eggs, and we sent them a questionnaire to ask them that why have they never not used their eggs till now, and what are their plans. So when we looked at demographic characteristics, we had 41% of these girls freeze their eggs between 31 to 35, and 46% freeze it between 36 to 40. So the majority froze their eggs between 31 to 40. Yet if you see, less than half froze it at a time when it sort of the recovery is best and the embryos make the best quality embryos also. AMH, the lowest AMH at which people came running to us was 0.17, and the maximum was 6.13 nanograms per ml, and the mean was like 2.08 plus minus 1.60. There were girls who froze it before 30 years also, 8% only, and there were women who froze it above 41 years also, 3%. Now, if you see the girls who had, out of all these 84, 59 only needed one cycle for an adequate number of eggs to be frozen. 25 needed 2 cycles, and 2 patients needed 3 cycles or even more. Egg retrieved per patient, the minimum number was 3. And out of this, the egg frozen per patient, the minimum number was 1, where we could freeze. It is only mature oocytes which are frozen, not all oocytes. The maximum number retrieved was 28, and out of this, 26 could be frozen. That is again the mature number of oocytes. So mean number was 14, and the mean eggs frozen were 11, which is okay for women who are less than 35, but not okay for women who are older. So if you see, out of 1,249 eggs were retrieved in total of 115 egg pickup cycles in 86 women. This is including, in these 86 women, there were 25 women who went through 2 cycles and 2 women who went through 3 cycles. And out of this 1,249 eggs which were retrieved, 976 eggs were only frozen, because these were the mature eggs which can later be used for conception. So a follow-up survey on the reproductive attitudes and experiences of women who underwent social egg freezing with us. Our aim was to assess the socio-demographic characteristics, reproductive attitudes, and experiences of women who underwent social egg freezing. The study design was retrospective, observational, questionnaire-based study, and inclusion criteria was only women who underwent social egg freezing. Methodology was a questionnaire was developed. It was administered to women. It was administered to women who underwent social egg freezing at Gangaram from 2016 to 2022. Since we wanted at least a follow-up period of 2 years, so we did not send this questionnaire to women who came in for egg freezing after 2022, that is in 23 and 24. Women were telephonically contacted and questionnaire was asked also. When we sent the questionnaire, very few women replied and sent back the questionnaire. So all those who did not were telephonically contacted. Number of women who responded out of these 42 were only 26. So let us see how we went through. So 42 women who underwent egg freezing from 2016 to 22, only 26 responded. Either the questionnaire was sent back or they responded telephonically. So what was the questionnaire like? Number 1 was highest education, school, graduation, post-graduation, employed, yes or no. What was your source of initial knowledge about oocyte cryopreservation, media, health professionals, friends or family? Were you married at the time of oocyte cryopreservation? Are you married now at the time of this survey? Any natural pregnancy before oocyte cryopreservation? Any natural pregnancy after oocyte cryopreservation? Why have you still not used your oocytes? How secure do you feel about future fertility now that you have your oocytes frozen? How do you estimate that you will use these oocytes in the next 5 years? Do you regret freezing your oocytes? These were the questionnaire. And highest education, if you see, most of these girls who replied out of the 26 girls were either postgraduates or graduates. 22 were employed, only 4 were not employed. Source of initial knowledge was equally from either health professionals, media, or friends or family. Why have they not used oocytes? So the largest, more than 50% said that they don't have a suitable partner till now, and a small percentage said that they are focusing on career. And a small percentage said that we are now trying to conceive naturally. If we don't conceive for 2 to 3 years, we will use our oocytes. And some patients, a significant number said 1 and 2, both are the reasons that we have not um, thought of freezing. There was a small segment of others which said, one said currently not thinking about kids, other said why the rush, I have time because I have oocytes cryopreserved. Third said I don't know if I want to have kids. Fourth said not ready for kids at the moment, not ready for kids at the moment. So, a majority of patients were still not ready to have kids, and most of them, the other group, the 5.19% said that they are not ready about kids. How secure do you feel about your future fertility? Majority said they were very secure, and moderate said they were 10 out of 26 and 11, which means 21 patients said they were very secure or moderately secure, but 5 said not secure because they knew that they have lesser number of eggs frozen and they did not know what would be the fertility outcome after these eggs are fertilized at whichever age they go for pregnancy. And this questionnaire, 26 answered, do you regret freezing your oocytes? And all of them said no. So they affirm that they have no regrets that they have frozen the eggs. Even if they never use them, they are happy that they have frozen oocytes. Now, let us see, out of these patients, how many thawed their oocytes. So we see only 3 patients came back and they used their oocytes. Patient A had 11 eggs. She froze her eggs at the age 43 in 2020. The eggs were thawed and used when she was 45, and the result of pregnancy was negative. All the eggs were fertilized. Patient B had 18 eggs. She froze her eggs when she was 30, and she came back and used her eggs in 2024 when she was 33, and she's pregnant also, and she has 2 more blastocysts frozen with us. Patient C again had 14 oocytes, age was 36, and we see again at 38 she came back for her pregnancy and all the oocytes used and her result is negative. So having oocyte frozen gives you a hope that you will get pregnant at a later age when you want a child, but it could also be hyped that, they feel so secure, but then when they reach 38 and they are not being able to conceive naturally. Another patient D, who had frozen her eggs in 2022, age 33, has married and conceived naturally now at age 36. So she's just been married, she conceived naturally, and her eggs are still frozen with us. Having said that, I also want to bring to you elective embryo cryopreservation is becoming very, very popular these days. These are married couples who are undergoing IVF only to freeze their embryos and delay childbearing. Now, freezing embryos give them a greater security of the number of embryos they have, especially if they are freezing it at an age less than 35, where euploid embryos are generally there. I mean, most of the embryos are euploid, very few may be aneuploid. So if they preserve 4 embryos at less than 35, we know that they have a good chance of having their own genetic child. And some married women even opt to freeze half of the embryos and freeze the other half as eggs to preserve their reproductive autonomy. And they are very open to this. In front of the partner, they say that I am freezing only half of my eggs with his sperm because I don't know in long term whether we are together, and then I might need my eggs again. So this is what is happening with modernization, with the society advancing into women liberalization, women empowerment, and women going in for career opportunities. So social egg freezing is definitely a great hope. It is generally well received by women who are mostly single and wish to buy time before starting a family. Majority of women, according to our questionnaire, do not regret the experience, and our study shows an overall positive attitude towards social egg freezing. But height, yes, age is an important factor. At what age these eggs have been frozen, and it is important to undergo this procedure at the right time or right age. Otherwise, it may be a false sense of security. And pregnancy rates would follow the present pregnancy rate of the center. Whenever you go for thawing and having them fertilized, if the implantation rate and pregnancy rates are high for that center, you may have, even with 2 blastocysts or 3 blastocysts, you may have a guarantee that you would have a live birth. But otherwise, it is not just egg freezing, it is also the fertilization rate, the implantation rate, with which eventually give the girl opportunity to have her own genetically related live birth. So concluding the talk, I would say planned oocyte cryopreservation appears to be generally well received by women who are mostly single and who wish to buy time while they seek a suitable partner to create a family. Most women who underwent oocyte cryopreservation do not regret the experience, and some have found a partner in subsequent years. Our study shows an overall positive attitude of our respondents towards social egg freezing, even though only a minority of women return to fertility center to use their vitrified oocytes. And I'll tell you now, a lot of couples come forward and say, we want embryo freezing. Then I say, okay, but you are just 31 and you want to have a child at 35. Why don't you try for a child when you want it? They said, no, we know that nothing is wrong. My husband's semen is okay. Everything of mine is okay. We want these embryos to be frozen for our second child. We would try our first child, and if we conceive it normally, we would be very happy to have it after 4 or 5 years. And then these embryos could be used for our second child. So, I've had in the recent days about 4 patients who came in with this request, that I sent them back and I said, why do you want your oocytes cryopreserved now? Your reserve is so good. You're only 31. You're married. She said, no, we don't want a child now. We want it after 35. And these embryos are for a second child. Limitations is variability and relatively short follow-up duration is there. We've sent this questionnaire only to women who had frozen their eggs either in 2016 or 2020 till 2022. And if you see the 3 patients who came back had frozen their eggs in 2020 or 2019. During the COVID years, we had very, very little social freezing of eggs. So 2020, we went almost like nil social freezing. So women who had frozen before 2018 have not come forward to have a child yet. Only 3 women returned to attempt pregnancy with their frozen eggs, constraining our ability to assess the likelihood to achieve a live birth with one's frozen eggs. Thank you very much for hearing me out.
Thank you so much, ma'am. As always, it has been such an elaborate and detailed assessment of the topic, and the way you teach us, it's quite crystal clear about how to go about it and how to counsel the patients. And the study by Nitisha was quite a eye opener into understand that how they have taken it very positively and how it positively impacts their life decisions. We have few questions on the chat box, ma'am. The first is by Dr. Priya. She's asking whether there's any age limit for social egg freezing, when we can say no to the patient and counsel them that it may not be of
I
use
think,
now.
it is both the things. Age is also very important, Priya, but it is also her ovarian reserve. I have had girls who are of Caucasian origin. At 42, 43, they have AMH of 2 and 3 nanograms, whereas our Indian girls decline the reserve very fast. So if she has a very good ovarian reserve, we can give them all the pros and cons that, at 42, even if we preserve 20 eggs, we don't know whether you will make one euploid embryo or not. So we have to give them the correct picture about it, that age is very important. for having a normal euploid embryo, and hence we generally refrain from freezing eggs, like I told you, whose reserve is very, very little. Or I think I would not want to preserve an egg from a woman who's more than 42, 43, even if she has a good reserve.
Ma'am, she also wants to know if the number of eggs required for at least one euploid blastocyst are 10 and we get 6 to 7 mature oocytes. Do we counsel them to undergo another stimulation cycle?
I did show you a very nice chart by the Poseidon where we saw 5 to 6 oocyte cumulus complexes were required to get one euploid under 35. So if her age is less, then you have to at least, we always say 15 to 20 eggs should be preserved in young women. If they are older, then there is no number limit, because euploidy is such a thing that we cannot ensure that, at 38, 39, 40, they will have a euploid embryo with even 12, 15 eggs preserved. So for a young woman, I feel 15 to 20 eggs preserved gives them quite a lot of assurance that they will have a euploid embryo when we fertilize them at whatever age, because the age of the oocyte is going to be the age of the woman we collected the oocytes. And what you've written, what should be done in women with bilateral dermoid, depends on how big is the dermoid, how efficient you are in laparoscopic or open surgery removal. AMH of 2.7 doesn't decline the ovarian reserve when you remove a dermoid cyst, but definitely if it was a bilateral endometriotic cyst, then a lot of ovarian tissue and follicles are peeled off with the endometriotic cyst. And hence, if it is an endometriotic cyst and the woman knows that she's not married, she's already 33, 34, in that case, we can preserve her oocytes and then remove her endometriotic cyst. But in a bilateral dermoid, if the dermoid is not very large, not larger than 4-5 centimeters in diameter, I would prefer removing the dermoid and then going in for preservation, because it has been known that any woman who goes through OCR with a dermoid can lead to complications of peritonitis if we puncture the dermoid by mistake. Should oocyte cryopreservation be considered for women with thyroid autoimmunity? This is one autoimmunity which does not deplete the ovaries so fast, but generally all autoimmune disorders do tend to reduce the ovarian reserve. So just see her ovarian reserve at 34 and 35. If she's still single and the ovarian reserve looks as if it is declining, then you can always do it.
Ma'am, do the age of the female at embryo transfer of this cryopreserved oocytes affect the success rate to some extent?
Should not really, but yes, now age is becoming also an important factor for even donor egg embryo transfer. And I think at our center, Dr. Gaurav has done a very good study. He did give a lecture that even though we say that uterine senescence never occurs, the uterus is always ready, but even the ART guidelines have stopped implantation of donor egg embryos also at 50 years of age. So I'm sure that women who are more than 40 years old, in between 40 to 50, there is an implantation factor which could negatively affect the happening of a pregnancy. This is being studied, and we need more studies to say that how much it is negatively impacting implantation or success.
There could be also increased incidence of adenomyosis with age. That is one more thing I think we should be
we have to remember
at.
that why do we say that get pregnant in your 20s or early 30s is because adenomyosis, fibroids, endometriosis, all increases with age. Even assault to the tube may increase. You may have some type of PID, and the tubal patency could also be affected. So after 32, 33, there is a rapid decline in fertility rate, and after 35, definitely yes.
Ma'am, Dr. Pallavi is asking a question in which she's saying that can we stimulate in 2 consecutive cycles? She says she has seen SCRs in oocytes when re-stimulated in the immediate next cycle, and good blasts did not form despite having a good reserve.
This could be an anecdotal case. This could be an anecdotal case, Dr. Pallavi. And please do not put it. It must be one case where you must have seen, but there are lots of papers which say Biostim, Duostim does
Biostim
not
has
in
worked very
yeah,
well for us also.
very well, and even the Duostim has worked very well. And if there are SERs and they are genetically related to the woman, then whichever way you stimulate, you will find SERs. What is your answer on it, Tejashri?
Yeah, I think,
SER
ma'am, SCR
occur
is
again and again?
not related to the successive stimulation cycles. It is more to do with the
Genetics
oocyte
of the
quality or
right,
genetics of the woman.
quality. Yeah.
Ma'am, what is your
So
take, and how do you counsel girls who come for oocyte cryopreservation, considering that only 3 women were back to us for embryo, formation, fertilization,
see,
and
all of
transfer?
them, 84, they did not respond also. There were 46 women who were sent the
Hmm.
questionnaire, 20, 46 or 42, and only 26 responded. So we don't know
Yeah.
about the rest. And then we did a follow-up of those who responded. Then we saw that 3 had come back and the 4th got pregnant on her own. So my feeling is very few women come back to use their oocytes. Either they get pregnant naturally or they are still planning their lives. I had a woman who used to come from US about 15 years ago, and every year she used to come and get 2 eggs frozen. She was plus 40 doing postdoc over there. I used to go on telling her, why do you do this to yourself? Why do you come here and torture your body with the ovarian stimulation cycle? This is not going to help you. But it was stuck in her mind that she wants her oocytes cryopreserved. And such women never return, to use their oocytes. Now we are seeing a trend. If you saw, then you saw that all women who had um, who had cryopreserved their oocytes just 2-3 years ago came back to use it. Those who had preserved it much earlier, 2016, 17, 18,
Never
19,
came back.
for
Yeah.
the silent year of COVID 2021, they
Hmm.
hardly came back.
Yeah.
So,
Ma'am,
we
can we just counsel them that we have your oocytes preserved with us, but once you get married, at least come back, get them converted to embryo so that at least at that age, you know what are they really useful for you or no, and
yeah,
then we can
correct.
preserve them in the form of embryo.
Yes, it would be very good to counsel them that way. And the
Yeah.
married women are getting half embryos frozen and half oocytes to have
Half
reproductive
eggs.
autonomy. And a lot of girls told me that, no, we are freezing it for our second child. First, we'll try on our own. This stuck to me, I am that baby boomers generation person.
Yeah.
And I said, okay, they want to have a child. I said, you could get spontaneously pregnant at 36, 37. They said, yeah, that's what we will try. But I want
Hmm.
to freeze these embryos for our second child. So, the thoughts are changing, the mentality is changing, the mental makeup is changing. So, girls don't mind spending a lakh of rupees, those who are well off. They just feel, oh,
Absolutely.
this is
And
a
a
lot.
lot of MNCs are now sponsoring this whole program,
Yes, yes.
oocyte
Earlier,
freezing program.
our oocyte freezing in 2016 used to cost 65,000 with everything
Right.
in it and the medicines. Now the cost has gone up to about 95,000. With time now from 2016, we've moved to 2025, almost 9 years down the line. But otherwise, I think it used to look like, peanuts to girls who could manage and they would just come and get. But the problem was that then mostly girls of age would come to us, 39, 40, 41.
Right.
Now younger women are coming more often and they
Now
understand
we have 25 and 28 years old coming and getting their eggs
asking for
preserved,
it, But then if you see
which
the
is something
AMH,
we welcome.
welcome, but we have to, I mean, if they have a low reserve at 25, 28, we have to encourage them to have a spontaneous pregnancy. But if they are not ready and they say, no, we want to have a pregnancy after 30, then I think we welcome them. That yes, get them preserved because your AMH is already low, and especially if they have some chronic illness or autoimmune disease or a genetic history that mother had a very early menopause, then it is very important to, preserve their
Then it
oocytes.
becomes more of a medical egg freezing rather than social.
They want to
Ma'am,
delay.
Dr. Priya is asking that if they want to extend it for more than 10 years, what to do?
I'm sure we
I
can do
think we
it.
can Yeah, we
We
can
can
do it.
definitely do it 10 years. Semen preservation, we can do for lots and lots of years. So we can definitely know, but we don't have studies on the embryos made for oocytes preserved for more than 10 years, enough studies to say that it is safe. The same thing is for embryos. So even the ART bill has given 10 years as a downstream line period, that at least preserve everything for 10 years. After that
10 years.
depends on the patient. You see, when
Yeah.
you extend the freezing for more than 10 years, they are paying every year for your freezing cost. And freezing cost is considerable. You are using your cryo can, you are replenishing liquid nitrogen every month into it, which is expensive. 25,000 या 30,000 का उतना liquid nitrogen आ जाता है जो replenish करना पड़ता है. So 10 साल से
And of
ज़्यादा
course, we do take consent from them if they want extension beyond that. We explain to them and
Yeah,
the
normally
usefulness, and
all
then if they
oocyte
are willing, we would.
cryopreservation, they preserve for 2 to 5 years at one go, so that they don't have to go on thinking about renewal. But very few would sort of preserve for 10 years. They come after 5 years to renew it. So let's see what happens in the long term.
Thank you so much, ma'am. We don't have any more questions in the chat box. I'm sure the topic was so much clear after your detailed discussion. And everybody always benefits from whatever you teach us. It's
Yeah,
like
even
a
I benefited from this. When I made this, then I thought that it is so much of a hype that, see, out of 3 patients, 2 had only one blastocyst and they did not conceive. So that security which was in that girl's mind while cryopreserving her oocytes at 36 and 38 just went down the drain in 1 minute.
right. So it is really motivating for us to really find out that those who are doing the freezing program, how much is it
Should
getting
come
utilized
early.
really?
At
That's a
young
food for
age
thought.
and enough eggs. Young
Yeah.
age, enough eggs so that they make 3, 4 blastocysts. Then we
Yeah.
can cure them a live birth. Now,
Right,
this
ma'am.
girl at 33 had 4 blastocysts and she got pregnant with the first. If she would not, we had second and third and fourth also to take a chance.
Good.
All right. Thank you so
Thank
much.
you, ma'am. Good night. Thank you, everyone, for joining today.
All right. Mr. Dave,
Yes,
Vishal,
ma'am.
thank you so
Yes,
much
ma'am.
for always being there for us. And I
Same,
really
ma'am.
thank you from the bottom of my heart that, I wanted to go sort of do this masterclass teaching. I am a clinician, but I love to sort of give my thoughts forward to willing doctors who are wanting to learn from me. And it gives me a great platform by you supporting us. And Dr.
Thank you,
Tejashri
ma'am.
is there. Dr. Bhavani is not there, I think, today, but Tejashri and
No,
Bhavani.
ma'am, I'm there. I'm there, ma'am. I'm actually out of station. That's why I thought
So
that there will be
why
a
were you
network.
so silent? You were the 2 motivators who made me do this.
No,
You
ma'am,
said,
I
"Ma'am,
listened to the
master
whole
classes
lecture.
and we'll be the moderator."
I listened to the whole lecture, ma'am. I had a few questions also, but I think time was less.
No,
So,
no, there's time. बोलो अभी 8 minutes हैं.
no, ma'am, I just wanted to know कि when we are counseling the patient, so should we take into account our oocyte survival rate, our embryo conversion rate also?
Yes,
Because their
very
main
important.
question is how many eggs is enough. So
I
the
told
age
you,
is
no, that I did tell you that it is on the center's fertilization rate, embryo conversion rate, that everything will eventually.
Also, I think, ma'am, the interpretation of the data is limited because we haven't been able to use them enough. Only then
Everywhere in
would
the
we know
world,
what
there
is our
are
survival.
cans and cans full of cryopreserved
Yeah.
oocytes. Out of the celebrities who have had 2-3 ने use किया होगा. So, Bhavani, your question is so correct that we said we don't know the safety, we don't know how what is going to be the thawing rate, but now oocyte cryopreservation by vitrification has become quite robust, and centers who do good vitrification may be able to thaw more than 95% of their oocytes. And fertilization will depend on that center's fertilization rate. And I very clearly said that, where you preserve your oocytes, when they thaw and they fertilize, that center's fertilization rate at that point of time will determine whether this program is really going to help your patients or not. The age of freezing, the number of eggs
I
which are
think
being
what
frozen, and the center.
Bhavani wants to highlight is, Dr. Bhavani, do you mean that it leads to some zona hardening and makes fertilization a bit difficult.
Yes, ma'am, because the embryo conversion rate with oocyte freezing will differ
Preserved oocytes
from
is a little less than
the
compared
fresh
to
Yeah,
fresh
because
oocyte
embryo.
embryo conversion.
frozen oocytes, Tejasvi, always undergo ICSI. There is no
Yeah,
IVF done for them because of zona hardening only.
yeah,
So
yeah.
ICSI will overcome this problem of zona hardening, but oocyte survival after thawing for many centers is still quite low because oocyte is a large cell, and if crystal formation happens, then that oocyte will not survive on thawing.
Survival
So
becomes
only
difficult.
centers who say that 98% is the survival rate. So you have to ask these questions from your doctor. This is for patients, or doctors must tell them that, see, our oocyte survival rate is low. If you have your own sister to preserve, you will want to go to a center where the oocyte survival rate is high, the fertilization rate is high, and the blastocyst conversion rate is high. And frozen eggs may not fare as well as fresh eggs, like Bhavani asked.
And ma'am, if a
Anything else,
patient is
Bhavani?
ready to undergo multiple cycles, how many maximum cycles would you recommend?
I would not recommend more than 20 oocytes freezing for a girl, but yeah, if she's so worried, if she's more than 35 or more than 38, then maybe more oocytes, but otherwise 20 oocytes should give her a fair possibility. Out of all girls who freeze their oocytes, 30% will have a fair possibility of having their own live birth, not more than 30% after frozen oocytes. So this is very important to counsel them with, like you said, that I would tell them that if we've frozen 15 to 20 oocytes, then you have a 30% chance by IVF, which is there with all IVF centers. When girls come and have IVF, what is the live birth rate we give them? Not more than 30-40%. So here also the live birth is not going to be more than that. This is what we have to make them understand. But if they are young and they make more blastocysts, then maybe yes. Bhavani, very difficult to really say how many embryos they will make eventually. And it is early age of freezing, which is the most important factor in my mind. 20 eggs from a girl who is less than 35 should give us assurance that she will end up with a live birth. What do you think? You give your opinion. Tejashri, you give your opinion. How many would
Right,
you want?
ma'am.
Bhavani, how many
Yes,
would
ma'am,
you?
at least 15.
15 for
15 to 20 eggs frozen will give you assurance in a younger than 35-year-old.
Yes,
Older,
ma'am.
very difficult to preclude aneuploidy.
Ma'am, but if a patient with low reserve, not very advanced age, but up to the age of 37, 38, comes for egg freezing, she's ready to undergo multiple cycles. Should we tell her to go
I
ahead?
I would discourage someone where we get just 1 or 2 sites. But if you can get 6 to 8 or 6 to 9 oocytes in every cycle, then we can encourage her to go through 2 and 3 cycles. If you saw my figures, there were 3 women who, and 3 or 2 women who underwent 3 cycles of stimulation also to get the numbers which they thought was appropriate. So I would encourage not more than 2 cycles. I would not encourage women with a very low AMH. Very recently, I sent a woman back who already had 1 oocyte frozen in a very reputed center. So I told her that no, you should not go through oocyte cryopreservation because your reserve is very low. So you should get at least 5 to 7 oocytes to go through 3 cycles of stimulation. Otherwise, no. And you have to counsel her that you will need to go through 2 or 3 cycles. What is your opinion, Bhavani? What will you do? You are the future
Yes,
clinician.
ma'am, I agree, ma'am.
That you will have to counsel that
Yes.
3 cycle हमें 15 oocytes अगर free.
Sometimes they're very adamant कि कुछ भी कर दो, थोड़े बहुत ही कर दो, then we have to
नहीं, just tell
accordingly
them that
counsel.
थोड़े बहुत से you can make
फायदा नहीं है.
embryo and you may not be able to make
yeah, we have to
15.
realistically counsel them
हाँ,
that
कि 15 oocyte complexes कम से कम होनी चाहिए for you to have an adequate chance if you are less than 35. And like Bhavani's patient who's 37, you have to tell her that you have to have 20 oocytes. चाहे 2 में कराओ, 3 cycle में कराओ. Yet, I wouldn't do it for anyone where I think I need more than 4 cycles for cryopreservation. I would refuse them, that you are not the fit person to have a cryopreservation done because you will need 4 or more cycles.
All right.
Thank you, ma'am.
Thank you, ma'am. Thank you so much. Good night. Good night, everyone.
Bye-bye.
Good
Good
night.
night, everyone.
Support team, end the meeting.
Sure, sir. Good night.
Good night.